Good afternoon, everyone, and welcome to the Overcoming Hip and Knee Pain webinar with Dr. Nathan Haile. I'm Terry Armstrong. I work for Texas Orthopedic Specialists, and we are one of the presenters, as well as Texas Health Southlake Hospital. Let me see if I can, give me 1 second to get this. There we go. So Texas Orthopedic Specialists, I'm going to tell you a little bit about our group. We are comprised of board-certified, fellowship-trained orthopedic surgeons and subspecialized doctors. We provide North Texas with comprehensive orthopedic and sports medicine solutions. And we have 3 offices, one in Bedford, right off of Harwood and 121, one in the Keller Alliance area off of Golden Triangle and North Riverside Drive, and we have an office in Denton, and that office is located next to Medical City in Denton in the professional building. And before I introduce our speaker and give you a few little tips of how the webinar is going to work, I'm going to toss it over to the marketing director for Texas Health Southlake, Jenny Lanier. She is, as I mentioned, the co-sponsor, or the hospital is the co-sponsor of this event. So I want to give her a chance to tell you all about the hospital. Jenny?
Thank you, Terry. Hi, everyone, and thank you for being with us today. Like Terry mentioned, I am the marketing manager at Texas Health Southlake. We are a multi-specialty surgical hospital. We are located right next to Central Market, across from Southlake Town Square. We are actually Southlake's first hospital, and in October, we've been serving the community for 16 years. We do have a 24/7 emergency room. We have 3 physical therapy centers. We serve over 18 different surgical specialties. And so if you would like to learn more about what we do, who we are, you can go to texashealthsouthlake.com, and you'll be able to find a full list of all of our services and our physicians. And we are just very thankful for Texas Orthopedic Specialists for being a co-sponsor with us today, and a special thank you to Dr. Nathan Haile for being with us today to filling us in on some information on the hip and knee. So thank you, Terry.
Thank you so much, Jenny. Let's move on. Okay, so before we start and before I introduce Dr. Haile, I just want to encourage you all to use the questions section, or the tab that you should see. If you're on your phone, it should be at the bottom. If you're on your desktop, you should see a questions little tab, and type out any questions you have for Dr. Haile on this topic. Later on in the webinar at the end, I will have one last slide that has all of our contact information. And it'll have my email, so you are welcome to email me questions later. And if you share this with friends, to have them email me questions, and we'll try to get them answered after Dr. Haile's talk or later on through email. Okay, Dr. Haile. So he is an orthopedic surgeon. He is fellowship trained in joint replacement of the hip and knee, and he also specializes in revision hip and knee replacement surgery. We are so proud to have Dr. Haile as a part of our Texas Orthopedic Specialist team. He joined our group last year in September, so he's now going on a year with our group, and we are just so thankful and proud to have him. So Dr. Haile, when you're ready, I'm going to toss it over to you so you can start your talk. Let me get this going. There we go.
Thanks, Terry. I'm happy to be here to talk about hip and knee pain and some of the solutions, both surgical and non-surgical, that we can incorporate today. And so without any further ado, we'll get started. Y'all feel free to leave questions on the question panel that Terry talked about. And thanks to Jenny and Southlake for having us on. All right, so a little bit about me. I was born and raised up in the panhandle of Texas in a little town called Friona. I went down to Texas A&M for college, and then to San Antonio for medical school. I did my residency in Temple, and then I finished my training in Salt Lake City, where I did an extra year exclusively in hip and knee replacement. And at that place, I did over 500 joint replacements. So a little bit about the anatomy of the knee. This is a front view of the anatomy of the knee. The knee's made up of the patella, which is your kneecap, the femur, and the tibia. In between the femur and the tibia are these little cushions here called meniscus or menisci. This is the anterior cruciate ligament or ACL. This is the posterior cruciate ligament or the PCL. And then these two on the sides are the MCL and the LCL. And so with those ligaments, make up the stability of the knee. A view on the side shows all the same things. You can see really nicely here this white part, which is called the cartilage around the knee. And that's the part that wears out in arthritis. And when it's gone, we develop bone on bone arthritis, and that's the cause of a lot of knee pain. The hip is obviously different. This is a picture of the hip capsule, which is the strong ligaments that keep the hip in place. This is a view of the dislocated portion of the hip, which you can see the femoral head and the same kind of cartilage here that was on the knee. This part's the femur, which is the ball part of the hip. And then here's the socket, and we also call that the acetabulum. Similar to the knee's meniscus, the hip has a labrum, which is right along the outside of the acetabulum. And then here you can see a cross-sectional view through the hip, which shows the blood flow up into the femoral head by these vessels. And then again, the strong ligaments outside the hip. And then this is the socket with its cartilage here. And then the ball part of the hip with its cartilage here. So that's an overview of the anatomy of the knee and the hip. So what is arthritis? Well, it's defined as painful inflammation, which leads to stiffness in the joints, and there's multiple kinds. And so they're in a couple of different broad categories, with the first being inflammatory arthritis. And different types of inflammatory arthritis are rheumatoid, lupus, scleroderma, ankylosing spondylitis, or psoriatic arthritis. And these are all very rare. And for the most part, they're treated with medical treatment rather than surgery due to many of the great strides that have been made over the last 50 to 100 years in the treatment of these diseases. The more common type of arthritis is called osteoarthritis. And this is your typical bone on bone or normal wear and tear arthritis that typically is related to age. So this is a degenerative process, meaning once it starts, there's no going back. We can slow it down, we can treat it, but in 2020, there's no cure that reverses arthritis or regrows cartilage or anything like that. It's also an inflammatory process, which I think leads to a lot of the pain. And so a large part of the treatment algorithm for treatment of arthritis is treating the inflammation related to arthritis. Some of the risk factors are muscle weakness, heavy physical stress. So if you stand a lot or work a lot at your job or have a job that requires high impact exercise or high impact sports, these are things that you can do, or things that are lifestyle choices that you can make to improve the arthritis in your life. And these are things that you can change. Now, there's also some things you can't change. So being a female changes or puts you at higher risk for arthritis. Your age and your genetics also are risk factors for arthritis, and those are things we can't change. And here's a picture that illustrates arthritis in the knee, and it shows that pearly white cartilage is worn away in several areas, and that's when the cartilage is gone and the bone rubs on bone, that's when we start having significant pain. Here's a picture in the hip, and again, that pearly white cartilage is worn away, and then when we start having bone on bone changes is when the pain starts to really increase. So some of the symptoms that are related to arthritis, obviously pain. I would say not all knee pain means arthritis, but typically if you have arthritis, you're going to have some level of pain. You can have some swelling. You can have worsening of a bow-legged or knock knee deformity in your knees. You can have stiffness. A lot of patients complain of a feeling of instability, or they feel like their knees are giving way. A lot of the time that's related to pain rather than actual instability related to the ligaments. You'll typically have increased pain with walking or standing, and it'll get better with sitting. So what does arthritis look like on x-ray? This is a picture. This is a patient with very mild arthritis. You'll see there's a bright white line here, which is significant, which symbolizes sclerosis, and that means that's one of the first signs of arthritis that you'll see. There's a small bone spur here, and there's a small bone spur here, and then also smaller bone spurs here and here. And then you'll notice that this space is much smaller than this space over here. So this knee is wearing out preferentially on the medial or the inside aspect of the knee, and that's why that joint space is bigger than this joint space, or is smaller than this joint space. But those are kind of the three things that will happen in arthritis. You'll see sclerosis, osteophytes or bone spurs, and then joint space narrowing. A little bit more progressed view of arthritis is here. So you can see the bone spurs are a little bit bigger. The sclerosis is a little bit more advanced, and the joint space is ultimately very small and almost gone in this knee. And then this knee is an example of a destructive pattern of arthritis. And so this is on this knee, you see cystic change, you see complete collapse of the tibia, and this is just very advanced arthritis. On the hip side, this is an example of mild arthritis. You see the sclerosis here, very mild bone spurs and small joint space narrowing. This is a more advanced example of hip arthritis, where there's relatively no joint space left. You've got these big osteophytes and then a lot of sclerosis. And then this one's a little bit harder to see, but he has complete obliteration of the femoral head and the acetabulum starting to be worn away, and this is more of a destructive pattern of hip arthritis. So if we're looking at the hip and knee, how do we get from this, which is pretty bad arthritis, and then these are just a couple of more examples of the sclerosis, the joint space narrowing, and then the osteophytes, which are all, which we kind of went over on the last slide, then illustrated again here. And as we talked about beforehand, this is a degenerative and an inflammatory process. And so the treatment philosophy in 2020, like I mentioned, there's no known treatments where we can just erase arthritis or take it away. And we take a team approach, and there's many non-surgical options that we can use to slow down the degeneration or to decrease the inflammation. And so just because you have arthritis doesn't mean you're going to have surgery, but it is kind of one of the things that I want everybody to know is it's not reversible, but it is treatable. And so certain lifestyle changes that you can take, if you've got extra weight on, losing weight is going to really help your knee pain, especially. It helps hip pain too, but to a lesser degree. But really, knee pain is quite affected by the amount of weight that you're carrying. Exercise can help, but sometimes when arthritis is bad enough and the hip or knee pain can actually prevent patients from being able to exercise the way they want to. And so then we start looking at low impact options such as therapy in the pool or exercise in the pool. And then the biggest thing and the hardest thing is to know what to eat. And so being able to control and just police what you eat on your own is very difficult. And so we've got some resources such as medically supervised weight loss, where you go to a doctor and they provide some accountability and some dieting plans where they, and even sometimes medication, where they really help you to figure out in what ways your diet can contribute to your weight loss. And then also some patients end up having bariatric surgery. But overall, weight's a relatively big issue as far as hip and knee pain, and getting that weight off can really help. Other things that we can do is use an assistive device like a cane or a walker. I think those are good options for some people, but there's another group of patients who are just too active, and a cane and or a walker is really just not going to work for them. So you can use a toilet seat riser, you can use a sock or a shoehorn to help you get dressed, and we can use home exercise programs. And all these things are relatively easy, relatively cheap ways to facilitate and treat your knee pain or hip pain. So when those things don't work, and most people try those types of things on their own, and then when they get to my office, we start talking about more formal ways to treat hip and knee pain. And so physical therapy is a nice option, especially in the knee when you've got your quads and your hamstring muscles around your knee, and as patients age, sometimes they get relatively weak. And so getting those strong again can greatly help knee pain in some patients. The oral medications that are recommended to treat arthritis are anti-inflammatories, and some of those are ibuprofen or naproxen. The brand name of those is Advil or Motrin for ibuprofen, or Aleve for naproxen. They have these are over-the-counter medications, and they have strengths that are prescription strength, but we can recreate those just with the over-the-counter medicine. So I typically start with those. If somebody has kidney trouble or stomach trouble, then sometimes we'll use these other anti-inflammatories, which are more selective and have less side effects. And so examples of those are meloxicam or Mobic and Celebrex. And tramadol is also recommended as a treatment option for patients with knee pain. Tylenol is not recommended because I think it's not as effective in some patients, but especially if I have patients that are over 80, they seem to do really well with Tylenol. So I'll use that from time to time. Injections are another option to treat knee pain. I typically start off with steroids. There's another option that's called viscosupplementation, which goes by a lot of kind of vernacular names, such as gel injection or rooster comb or the lubrication injection. I've heard it called a lot of things, but that's kind of a second line for me. And then platelet-rich plasma is a treatment that's kind of experimental at this point, but it's starting to gain traction, and I think it's a really good option for patients with mild to moderate osteoarthritis. This is a process where we pull blood out of your vein and then we spin it down in a centrifuge to get the platelet-rich portion of that blood and then inject it back into the knee. And it's really kind of a nice alternative to other types of injections or to surgery. There's a lot of interest right now in stem cells and whether stem cells can help. And from what I've been able to see and the research I've seen, there's no indication for the use of stem cells in the treatment of arthritis. Now, if there's other pathology or other problems besides arthritis, there may be a role for stem cells, but at this point, I don't recommend stem cells for the treatment of hip or knee arthritis, and in fact, I will typically recommend against it. But that's another option that is available to some patients if they seek it out. So sometimes we can consider a knee scope or a knee arthroscopy if the pain is if the arthritis isn't overly bad. And so typically in my practice, I'll see patients that have pretty bad arthritis on one side, but it may not hurt. And then they have moderate or mild arthritis on the other side, but that's the knee that hurts. And so if that's the case, then I'll typically get an MRI, and more times than not, we'll find a meniscus tear that sometimes can be treated with a small arthroscopy procedure, which is much less invasive and can typically provide a pretty good relief for these patients, especially if they're having clicking or catching or popping that's painful. Beyond that, hip and knee replacement is kind of what we're looking for as far as surgery goes, and these are the two most common joints that are replaced in the United States. And so in 2018, there's an estimate that by 2030 in the US, we'll do over 600,000 total hips and over 900,000 total knees. And so just a little bit about knee replacement. Knee joint replacement falls into two major categories. The first is total knee arthroplasty, and the second is either partial or unicompartmental knee arthroplasty. So this is a total knee, and this is a picture of a unicompartmental or a partial knee. And so I'll go over this quickly. In the total knee, the entire femur portion is capped, and so that's when there's arthritis in both the lateral compartment and the medial compartment. And so that's the ends of the femur is shaved off with a saw, and it's capped with this metal part of the femur. The same thing's done on the tibia, and then this plastic insert goes in the middle. As opposed to a partial knee, where you can replace either the medial compartment, the lateral compartment, or the patellofemoral compartment. Now, by far, the most common of the partial knees is a medial compartment partial knee replacement. But overall, it's the same basic premise. The arthritic portion of the bone is cut from the femur and the tibia and replaced with metal caps, and then the plastic piece slides in the middle. So a hip replacement is, here you can see a normal hip as opposed on this side is an arthritic hip. So in the hip replacement, the neck is cut here, and as you can see here with the hip replacement, the socket is reamed out, and a metal socket with a plastic liner is placed, and then this femoral stem is used to replace the femoral head. And so who's a candidate? So on the knee side, I do look at age, and I try to avoid any kind of arthroplasty in patients under 50, and almost never for patients under 40. And that's for two reasons. Number one, arthritis typically isn't bad enough for patients under 40. And patients under 40 or under 50, and then definitely under 40, just really, really struggle with a knee replacement. And I'm talking about in the postoperative period. So we'll talk about some of the reasons why a little bit later in the talk. But on the hip side, ideally I wait till they're over 50. But as opposed to the knee, there are many patients that are going to benefit from a hip replacement prior to age 50, and sometimes even prior to age 40. So the things I look at on X-rays is there bone-on-bone arthritis, and what are the symptoms, and are they severe, and then what previous treatment has been done. And so in my practice, I treat surgery as a last resort, and so I don't like to offer joint replacement to everybody that has hip and knee pain, and then you may ask why. So number one is what we talked about just a few moments ago about the satisfaction, especially with total knee. There's a risk of complications, and sometimes the complications can be really bad, and they can really affect a patient's life and can sometimes even make them worse. If the patient's young, then we always have a discussion about the need for future surgery, and if there is a need for future surgery, that can also be quite complicated. And so we try to shoot for just one surgery at a time if we can, or one surgery for the entire life if we can help it. Now, this is what I was alluding to on the total knee side. Almost all the literature that's looked at satisfaction after total knee replacement shows that anywhere from 15 to 20% of people are not happy with their knee replacement. And so what does that mean? Well, in the literature, we try to ask patients, would you classify your outcome or your result of your knee as excellent, good, fair, or poor? And we want everybody to be in that excellent or good category, and we want to keep as many people out of the fair and poor category. But despite our efforts and despite tons and tons of research, we still have 15 to 20% of all comers that fall into that fair or poor outcome. And so what I've been able to kind of figure out is the patients that are going to be less satisfied are young, so less than 55. They're going to be very active, and so runners or patients that do things like CrossFit or other high intensity interval training exercises, they may be less happy. And then if you don't have bone-on-bone changes on X-ray, your recovery is going to be quite a bit slower. And so my job overall is to make sure that you're happy. And so if age and imaging are appropriate, meaning you're over 55, kind of in that 60, 70, 80 range, and you do have bone-on-bone arthritis, And we've tried all the things we talked about, like anti-inflammatories and injections and physical therapy and staying active and weight loss. Then we asked ourselves a few questions. And I use these 3 questions to help patients understand. So number 1, do you have daily severe pain? That's pretty self-explanatory. I also ask, does pain limit your daily activities? And that's a little bit more subjective. So you get to decide what your daily activities are, and you get to decide if your pain is actually limiting you. So I've got plenty of people that say, well, yeah, my knee hurts, but it doesn't limit what I do. So, and I don't want surgery, so I'm going to avoid it. And so when I tell those patients, that's great. Let's, come back and see me when you can't do what you want to do. And then the last one, and I think one of the most important questions that patients have to ask themselves is, do you make major decisions based on your knee pain? And a major decision can be a lot of different things for a lot of different people. So I had one lady tell me that I asked her if she made major decisions based on her knee pain, and she said, well, yeah, I don't go grocery shopping because if I walk to the back of the grocery store and I get to the milk, I wonder whether I'm going to be able to get back to my car. And so for her, that was a major thing, and we proceeded with a knee replacement, and she was able to get back to her grocery shopping. In my training, I had a guy that was 80 years old, and he said, well, I'm making major decisions because I can only go snow skiing 40 days a year, and I want to do 80. And so we got him a knee replacement, and he got back on the slopes. So those are very different things for very different people. And so those are each patient is an individual, and we're going to look at each individual patient's desires and goals, and we're going to try to figure out a treatment plan and all the treatment options that can help them get back to what they want to do. So this is a picture of some examples of knee replacements. And so here on the right's the knee replacement I did. And so the femur or the tibia part is metal here. This fuzzy part's the cement that's used to fix the metal part to the bone, and then this is the femur component. These are pictures or cartoon drawings of the actual prosthesis that's used. And so this is the femur piece. This is the plastic that goes in the middle, and this is the tibia piece. The reason you can't see the plastic is because plastic doesn't show up on x-ray, but that's right here. And then this is a side view that shows how the knee works and how it bends. Oh, sorry. So this is a partial knee replacement where, and as you can see, this patient did not have arthritis over in the lateral compartment, but only did in the medial compartment. So replacing the medial compartment enabled this patient to get back to their activities of daily living. And so this prosthesis is pictured here, and that's what it looks like on the side, where it's got a femur piece, a tibia piece, and the plastic piece in the middle. And so as you can see, this is much less invasive and much more bone preserving than the total knee replacement. Pardon me. And so things you should consider when you're considering a knee replacement, and you may ask yourself, should I get a partial knee or a total knee? So we look at the x-rays. Are all the compartments involved? If they are, then it's no brainer, you do a total. If only one compartment's involved, then considering a partial is something we should do. Is the deformity correctable? So if you've got really bad bow-legged deformity that we can't even make straight in the office with a little bit of pressure, then we may not be able to make that partial knee work very well. Do you only hurt if you can put your finger on one spot in the medial or the inside part of your knee, then a lot of times that's a good sign that you may do well with a partial. And then are all the ligaments intact? Because if the ligaments aren't intact, the partial knee is not going to work very well. And age is something we consider to some degree. So these are 2 relatively similar knees. You'll notice that the bone on bone changes is a little bit more here than it is here. But overall, we've got medial sided collapse here, medial sided collapse here with the sclerosis, joint space narrowing, sclerosis, joint space narrowing, small osteophytes, a little bit smaller osteophytes. But but either one of these patients could probably have a total or a partial. But this patient, we decided, was a little bit further along, and they ended up with a total. And then this patient was not as far along and ended up with a partial. And both have been really happy and with their outcome. And so If we're thinking about a partial, the benefits include it feels more normal. So a total knee is going to feel more mechanical. You're going to have typically a little bit better range of motion. It's going to be more bone and ligament preserving. It's typically a less painful and a little bit easier recovery because we don't cut as much bone. And then if we have to change it to a total knee later on down the road, it's typically an easier second surgery or an easier revision. On the flip side, the risks include there's a little bit higher failure rate and a little bit higher risk of further surgery. On the other hand, a total knee replacement it's a more common procedure. The outcomes are very predictable. They still provide excellent pain relief, and the risk of revision in the first 10 years is lower. The risks include a little bit higher risk of stiffness and a little bit longer pain and rehab. In my practice, when I'm trying to decide or when I'm considering a patient with knee pain that needs surgery, I will offer them a robotic total knee or a partial knee. This is a screen, and I'll just skim through this, but this shows us exactly the amount of bone we're going to take away, exactly how the prosthesis is going to fit, and then these numbers show us the balance of the knee that we're going to have when we're done. And so we can plan the surgery and plan the cuts before they're made, and we can make adjustments on how we do the cuts in order to give a more optimal balance and hopefully a better outcome. The way it's done is we get a CT scan, and this is a picture of the CT scan, and the CT scan creates this image, and so we use probes that match what the CT scan knows that the bone looks like to where the bone is in space, and then that communicates with the robot, and then the robots help make the cuts. And so this is a picture of how the screen you see when you're making the cuts, and this is the example of the saw blade, which shows in real time how much bone that's being taken away. Advantages of using the robotic total knee is a little bit more precision. You can make very, very minor adjustments to tweak that final outcome, and it helps achieve optimum balance. And then the last thing is this green border is what's called a haptic boundary, and so that prevents the saw from going out and cutting any other kind of ligaments inadvertently. If you'd like to see an example of how we do this, you can look at this website, and these slides will be made available to you, but you can just click this link and it'll take you to the video that we made about robotic total knee replacement. On the other side, these are some examples of hip replacements that we've done, and this is a picture of what the hip replacement of the actual prosthesis looks like. So in general, the way that total hip arthroplasty is performed is typically there's arthritis in the socket, and so these hemispherical reamers are used to take away the residual cartilage and to take away the harder bone, and it's going to leave behind the softer bone that also has good blood flow, and then the socket is impacted into place, and then the friction fit holds the cup in place at first, and then it grows into these small pores in the back of the socket. The femur is prepared by using broaches, which create a pathway for the final prosthesis, and then it's impacted into place. So just like so on the knee side, the technology is less about approach, and it's more about how the procedure is going to be done, and that's typically either with a robot or with certain balancing tools or navigation or anything like that. Well, there is that to some degree on the hip side, but the bigger point of discussion at this point is what surgical approach is best for the total hip. And in my practice, I use an anterior approach, but this is an example of several different types of surgical approaches, and I'll go over them briefly. So this first green arrow here is the anterior approach, which you'll notice goes between this muscle here and this muscle here without cutting any of the muscles. And so the approach I do is more muscle preserving. This is a lateral approach, which goes through these muscles, and then this is a posterior approach, which does go through this gluteus maximus muscle. So in my practice, the anterior approach is typically the way that I access the femur or access the hip joint. And so The interval here is between this muscle, which is called the sartorius, and this muscle, which is called the TFL, or the tensor fascia lata. My incision is made here. This is cross section, which shows that it kind of snakes in between the muscles without having to cut any. So the anterior approach is muscle sparing. We don't cut any muscles. When we're finished, there's a decreased risk of dislocation. I'm able to use X-ray intraoperatively to make sure that the component is put in the right place and the right position. And the current literature shows that the recovery is quicker in the first few weeks after surgery when it's compared to other approaches. Now, long term, admittedly, the recovery is no faster with an anterior approach, over about 3 months, but in the first 2 weeks, it's definitely a little bit quicker. So these are tools that I use when I do an anterior approach. I use this table, and so if you have surgery, you'll have these boots placed on your feet, and then the boots go into these bars, and we use this table, which has the ability to manipulate the hip to put it in the right position for me to do the surgery. I also use this device, which is a grid that overlies the X-ray, and so we line these lines up to set points on the pelvis, and then we use this grid to make sure that the leg length here is correct on both sides. And so you'll see that this is the native side, and so we want this dark black line to pass through this part of the bone, this little bump called the lesser trochanter, and we want that to pass through the right spot on this side. And so this is not a particular shot from one of my surgeries, but it's more of a stock photo. And so if we're critiquing, we'll say this guy's a little bit long and would probably have to change the femoral head size at that point. But this is what we use to make sure that the hip's put in correctly. And so how do we get to surgery? How do we get from this horrible knee or this horrible hip to something like this, which is a well done replacement here or a well done hip replacement here? So after you've made the decision to proceed, you'll get a full packet. You'll talk to my scheduler. You'll get all kinds of information about which hospital you're going to go to and what to expect and how we're going to control your pain and what rehab's going to be like. Before this COVID pandemic, we would have patients go to what we call a joint camp, and they would go to the hospital and learn about what to expect. But now we have a really nice video. And then the timing's up to you, and it can be at your convenience. It's typically done at the convenience of the patient, but sometimes if there's more of a destructive pattern of arthritis, then I may push to do surgery a little bit sooner. On the day of surgery, you get settled in pre-op, you meet the nurse, you have your IV put, you'll meet with me and the anesthesiologist, and then we have the operation. After the operation, you proceed to your hospital room, you work with PT, and you're discharged to home on post-operative day 1, 9 times out of 10. And this is one of the most important slides, I think, is these are the advantages to having surgery in 2020. So we use what's called an ERAS protocol, or an enhanced recovery after surgery. And so we'll have you go see your primary care physician just to make sure there's nothing that you need to do to make yourself more healthy for surgery. We don't have you NPO for 8 hours. We make you stop eating food about 6 hours before, but you can drink clear liquids up until 2 hours before the surgery. We use modern anesthesia, and sometimes that's with a spinal anesthesia, sometimes it's with general. It just depends on your preference and the decision of the anesthesiologist. We put in a strong local injection during surgery to help prevent pain in that first 16 to 24 hours. We use tranexamic acid, which is a way to decrease blood loss. Actually for the majority of joint replacement history, people would be at pretty high risk of blood transfusion, and we almost never give blood transfusions in total joint replacement now. We use a lot of different types of pain medicine to limit the amount of narcotics you need. We don't use drains or catheters. We get you up quickly to therapy. You'll actually walk on the same day of surgery and do stairs the day after. And then we get you home. And so where 20 years ago, this was a 7-day hospital stay, and now it's as short as 7 hours sometimes. And so with that, I'll kind of leave it back to Terry and Jenny, and if y'all have any questions, I'll be happy to answer them. But this was kind of a fast and furious overview of hip and knee arthritis and the multiple treatment options we have, and then a little bit more in-depth look at surgery. But if you have pain in your hip or your knee, or if someone that you know does, please reach out to us, and we'll be happy to get you seen in a pretty timely manner. So thank you for tuning in, and I'll turn it back over to Terry.
Thank you so much, Dr. Hill. That was great. A lot of information, so helpful. We do have a few comments and questions. One patient, I said patient, I'm so used to saying patient. One viewer asked or made a comment, my pain comes and goes. I've been told it may be bursitis. Do you have any comments about that?
Sure. So especially if the pain is at the lateral hip, for years we called that bursitis. In the knee, bursitis is a little bit less common, but you certainly can have bursitis of certain areas of your knee. If it is the lateral hip, then a lot of times it can be related to the muscles around the hip, or it may be even related to the back. And typically that gets better with physical therapy. I'd say 9 times out of 10 it gets better with physical therapy.
Sorry, I couldn't find the mute button. Okay, so another lady asked, how long does a knee or hip replacement last? Does it typically have to be replaced again?
So again, early in the development of hip and knee arthroplasty, that we would tell patients that the hip and knee replacements would last about 10 to 15 years. And what would wear out is the plastic piece in the middle that I showed you on the knee, and then the plastic liner on the hip. And so the metal typically doesn't wear out, but the plastic will typically wear out. And what we thought was about 10 or 15 years. And with the first generation of the plastic, they would last about 10 or 15 years. It's really third generation plastic that's used now, were redesigned in the mid 2000s. And so we're 15, 16 years in at this point. And for the most of them, we're not seeing them wear out. And so I think we can safely estimate 15 years. I think it's probably closer to 20 or 25, but I don't necessarily have data that shows that yet, and I don't think anybody does. But I tell my patients that we can safely expect 15 years, but maybe up to 25 years.
Okay, great, thank you. And I have a lady that made a comment, and I wanted to get some clarification, but she asked, is walking, and I'm thinking she's saying, does walking deteriorate the knee if doctor suggests a knee operation?
So I consider your knees and your hips kind of like your tires on a car. And so if you go four-wheeling in the mountains a lot, your knees and hips are going to wear out a little bit faster. If you drive on the street all the time, they're going to last a little bit longer. And I'm not sure what that doctor may have been talking about, but what I'll tell my patients is if they have a diagnosis of arthritis, and I tell them that they would likely improve with surgery, but they don't want to do surgery, then I tell them to be as active as possible, because activity and motion typically makes those knees feel better. And if you get to the point where you can't be active, then I think that's probably going to start having you answer yes to my 3 questions, that you're going to have daily pain. It's going to inhibit your quality of life and your activities of daily living. And then you're also going to be making major decisions because you want to walk and you want to be active and you want to get your exercise in, but you can't because your knees hurt. And so I would let those 3 questions guide you as to when to pursue surgery. And so it's going to be less about what I say and less about what I see on the x-rays, and more about how bad that radiographic evidence of arthritis is making you feel.
Okay, one more question. If you have both, or if you need both knees replaced, do you recommend doing them at the same time?
That depends on a lot of different factors. I think probably the most important thing is your health. If you've got a lot of medical problems, then I would certainly recommend against it. If you have no medical problems, and they're both really, really bad, then I may say yes. I think it's a really, really difficult recovery, and so I prefer to stage them. They can be staged very quickly. I have one patient who had his total knee replacement done 2 weeks ago, and I saw him on Wednesday, and he's ready to schedule his next one. And so he'll probably have his done about 6 to 8 weeks apart. But the more common thing that I run into is patients come in and they say, well, I have 2 bad knees. I want to do them both at the same time, and I'll convince them to do one at a time. Well, then I ask them how they're doing at 2 weeks, and they're saying, I'm not ready to go with the next one. And then I ask them at 6 weeks, and they're not ready. And then about the 3-month mark, they say, well, yeah, I think I'm ready. And so most of the ones in my practice, I've done several where I've done both knees, but most of them are several months apart. Now, if you have really bad knees and you have what's called a knee flexion contracture, meaning that neither one of them will extend all the way, then yeah, I consider doing both at the same time. Or if you're young and healthy and just really want to get them both done at the same time, then I think it's a reasonable option. But it's my preference to do them at different times.
Okay, great. Thank you so much. That's all the questions. And do you have any last closing remarks, Dr. Haile?
No, I'll just say thanks to Terry, thanks to Jenny, thanks to Texas Health Southlake, and thank you to everybody that was involved in the talk. And hopefully that you have enjoyed this and it's been very informative. I'll point you to our YouTube channel for we've got a lot of good content on there that Terry's put up for us. And so if you have other questions, reach out there. And then if you would like to see us, we'd be happy to see you. So thank you again.
Thank you, Dr. Haile. And real quickly, everybody, I want to share with you some information on our practice, our contact. Dr. Haile mentioned our YouTube channel. That is right here. Just search in YouTube, Texas Orthopedic Specialists. Our Facebook channel, our Facebook page is right there at Texas Orthopedic Specialists, and our Twitter handle. If you have any questions or you want to schedule appointments, please call our office. And this slide is available in the handout section of this webinar, so you can always access it. I believe you can even go back later and access it. So that's our website. And if you have further questions, or if you share this with a friend and they have a question, email me, and I will always forward it to our doctors, to Dr. Haile, or if you have a question about anything, just shoot me an email and I'll get it answered. Okay, well, thank you all for joining us and have a wonderful day.